Chapter 26 of the 2018 Diabetes Canada Clinical Practice Guidelines is on the treatment of hypertension. My name is Alice Chang, and I'm narrating this deck on behalf of the chapter authors, Sheldon Tobe, Richard Gilbert, Charlotte Jones, Lawrence Leader, Ali Preptani, and Vincent Wu. Recommendations from this chapter are fully harmonized with those of Hypertension Canada. The hypertension checklist includes: assess for hypertension, defined as a blood pressure of greater than or equal to 130/80 millimeters of mercury. Treat to target, which is less than 130/80. Use multiple antihypertensive medications if needed to achieve target, which is often necessary. And consider earlier use of single pill combination therapy. The diagnosis of hypertension in people with diabetes is defined as a blood pressure greater than or equal to 130/80 millimeters of mercury, confirmed on a second occasion in either the office, home, or by appropriate ambulatory measurement. The reason that we care about hypertension and want to treat hypertension in diabetes is that we know that better blood pressure control in diabetes can result in fewer cardiovascular events. Here are data from the United Kingdom prospective diabetes study looking at individuals living with type 2 diabetes. Patients were randomized to receive less tight control of blood pressure or tighter control of blood pressure, and the mean levels achieved can be seen here on the slide. The less tight control group achieved mean blood pressures of 154/87, and the tighter control group achieved mean blood pressure of 144/82. Over time, you can see that tighter blood pressure control resulted in a 24% reduction in cardiovascular endpoints. In addition, a meta-analysis of 27 randomized trials showed that intensive blood pressure reduction by approximately 6/4.6 millimeters of mercury resulted in a 36% reduction in stroke, 27% reduction in total mortality, and 25% reduction in major cardiovascular events. As for the diastolic target of less than 80 millimeters of mercury, this was derived from the diabetes subgroup of the HOT study. In the diabetes subgroup of the HOT study, patients were randomized to different goals of diastolic blood pressure: less than or equal to 90, less than or equal to 85, or less than or equal to 80. And as you can see, the risks of developing cardiovascular events was significantly reduced in the purple group, which was the group that was asked to achieve a diastolic less than or equal to 80. Therefore, the target blood pressure for people living with diabetes is less than 130/80, and multiple antihypertensive agents may be needed to achieve the desired target. The algorithm for pharmacotherapy for hypertension in patients with diabetes is shown here. This is consistent with what is shown by Hypertension Canada. For an individual living with diabetes, let's start at the top part of this algorithm. If they have CKD or CVD, in other words, if they have chronic kidney disease or cardiovascular disease, then the first agent of choice is an ACE inhibitor or an ARB. However, if we look at the bottom part of the algorithm, if this person with diabetes does not have chronic kidney disease or cardiovascular disease, then the first agents of choice could be either an ACE inhibitor or ARB, or a dihydropyridine calcium channel blocker, or a thiazide or thiazide-like diuretic. Often, 2 or more drugs are needed in order to achieve control, and the use of drug combinations is recognized. Most people with diabetes should receive standard dose monotherapy for initial management. However, there is emerging evidence for supporting earlier use of single pill combination therapy. If you're going to use an ACE inhibitor or an ARB, check the serum potassium and creatinine at baseline and within 1 to 2 weeks of initiation. Remember that combinations of agents that block the RAS system, such as ACE inhibitor, ARB, and direct renin inhibitor, should not be used. More than 3 drugs may be needed to reach target values for people living with diabetes. Recommendation 1. Persons with diabetes mellitus should be treated to attain systolic blood pressure of less than 130 millimeters of mercury and diastolic blood pressure of less than 80 millimeters of mercury. These target blood pressure levels are the same as blood pressure treatment thresholds. Recommendation 2. For persons with cardiovascular disease or chronic kidney disease, including albuminuria, or with cardiovascular risk factors in addition to diabetes and hypertension, an ACE inhibitor or an ARB is recommended as initial therapy. Recommendation 3. For persons with diabetes and hypertension not included in other recommendations in this section, appropriate choices include, in alphabetical order, ACE inhibitors, ARBs, dihydropyridine calcium channel blockers, and thiazide or thiazide-like diuretics. Recommendation 4. If target blood pressure levels are not achieved with standard dose monotherapy, additional antihypertensive therapy should be used. For persons in whom combination therapy with an ACE inhibitor is being considered, a dihydropyridine CCB is preferable to a thiazide or thiazide-like diuretic. Key messages from this chapter include: people with diabetes should be treated to achieve a blood pressure of less than 130 over 80 millimeters of mercury. For persons with cardiovascular disease or chronic kidney disease, including albuminuria, or with cardiovascular risk factors in addition to diabetes and hypertension, an ACE inhibitor or an ARB is recommended as initial therapy. Healthy behavior interventions are supplementary to pharmacologic therapy and consists of reducing excess body weight, reducing sodium intake to around 2,000 milligrams per day, increasing consumption of fruits and vegetables, 8 to 10 servings per day, low-fat dairy products, 2 to 3 servings per day, avoiding excessive alcohol consumption, no more than 2 servings per day in men and no more than 1 serving per day in women, and increasing physical activity. Remember that most people with diabetes should receive standard dose monotherapy for initial management of hypertension. However, there is emerging evidence for supporting earlier use of single pill combination therapy. Key messages for people living with diabetes include: it is important to have your blood pressure checked regularly. Have your blood pressure checked at least once every year by a healthcare provider or more often if your blood pressure is high. You can also check your blood pressure at home. If home blood pressure readings are done properly, they may reflect your usual blood pressure more than those done in the healthcare provider's office. For most people with diabetes, blood pressure should be less than 130 over 80 millimeters of mercury. Patient resources on hypertension are available at Hypertension Canada. For more information on this chapter and other chapters, please visit guidelines.diabetes.ca or download the app on Android app on Google Play or available on the App Store. Thank you very much for your attention.